Sajel, are you still there?
I am.
Why can't I see you? I see you there. Okay. Here we go. Hang on.
Okay.
There you are. Okay. We're in good shape.
Okay.
Hello, everybody. Welcome. It's your Uncle Jim, and we're back tonight with our good friend, Dr. Sejal Patel. So tonight's guest, let me tell you what's going on. Tonight's guest on Kidney Stories 2 is Dr. Sejal Patel. She's a certified clinical research coordinator, kidney researcher, and prior kidney pancreas transplant patient. This is well, there are a number of firsts for this show, frankly. This is the first broadcast that I've done where I'm producing, and I am producing tonight on behalf of Kidney Solutions and my good friend, Kent Bressler. So this is our first broadcast together for this. It will be shared with the Urban Health Media Outreach Network, so you can catch the replay later. It's also a first for our show. Our original conversation, Dr. Patel and I, was supposed to take place on November 5th, 2021, but on November 4th, 2021, Sajel had her second kidney transplant. So she wanted to go forward, but we decided we'd reschedule because, you know, doctors overachievers. So we thought we'd give Sajel a chance to heal. She's a graduate from the Medical University of Silesia in Poland. She is board certified through the ECFMG Educational Commission for Foreign Medical Graduates and the Accreditation Council for Graduate Medical Education. She is also a clinical research professional, or you might see it abbreviated as CCRP, and a certified member of SoCRA, the Society of Clinical Research Associates. She has over 8 years of clinical research and experience with excellent therapeutic knowledge in the areas of transplant, medicine, nephrology, and general medicine. She's currently employed with the Clinical Research Studies Unit at the Mayo Clinic in Arizona, where she is working on projects like kidney research with the Kidney Transplant Group, studies concerning kidney transplants that last a lifetime by preventing rejection, taking kidney transplant patients off of immunosuppressant medications by injecting donor stem cells, and discovering meds to lower antibodies so people can be transplanted that have a high level of antigens. Please give a warm welcome to Dr. Patel.
Hi, everyone.
Oh, 1 minute.
Okay.
So, Doc, how are you?
I'm good. How are you?
Doing well. Let's get right into it. Did I correctly state all the information in the introduction about your background and your experience?
Mm-hmm. Yes, you did.
Okay. And let's see, I have to share a new banner. Hang on.
Okay.
All right. We're good, Jim. All right. Tell us a little bit about where you grew up, your education, your prior employment experiences, and how you came to work at the Clinical Research Studies Unit at the Mayo Clinic in Arizona.
Okay, I kind of grew up everywhere. I was born in Florida, and then we moved to Georgia, where my brother was born. And we kind of moved around a lot because my dad, he's an engineer in aerospace. So we kind of moved along with him. And then we ended up moving to, or actually, Alabama was where he was born. And then we moved to Georgia. And then from there, I think I was in kindergarten or first grade, we moved to San Diego in California. And that's where I pretty much grew up through elementary school, middle school, and then high school. And then my junior year, we ended up moving to Kansas. So grew up in the Midwest for a couple of years, went to undergrad for 2 years at University of Kansas, and then ended up moving to Arizona and grew up in Tucson for about 2 years, finished undergrad there. And then I ended up by myself moving to Poland for 2 years and did medical school out there, just did my basic sciences out there, and then came back to the US and lived in Chicago, Ohio, and then Tucson for my rotations. And then from there is when I got diagnosed with kidney disease. So from there, I ended up actually moving to Phoenix for my kidney transplant and been here since. So.
Okay. We talked in the introduction that you recently had a kidney transplant. So I want to start the discussion today off. Can you give us a little bit of your kidney history? What's been going on with our friend Dr. Patel?
So the last, so I just ended up being called for a kidney transplant since on November 4th. So that came out of nowhere, but I've been kind of waiting for a kidney transplant the last 3 years. So I had my initial kidney pancreas transplant in 2009, and the last 3 years I've just kind of been waiting because I ended up finding out that I needed another kidney, but my pancreas is still working fine. So kind of just thought I'd be okay the last 2 years, and then in January I ended up getting valley fever and ended up having to go on dialysis. And so kind of been through all modalities pretty much. Started on in-center hemo with the chest catheter access. I never ended up getting a fistula, so don't know what that's like, but I kind of refused that. I didn't want to get a fistula, so used a chest catheter and did in-center for a little bit and then did home hemo. But unfortunately, because my blood pressures were dropped so badly during home hemo, they kind of wanted me to be in-center just in case there was an emergency, and not having backup at home, it just was too risky. And so did in-center. And then my nephrologist, Dr. Nika, thought it would be better for me to do PD because that's what she initially wanted me to do. But I was always trying to push that off. I was like, I don't want to do it. And then I was like, you know what, that might be the best choice. So I can do at home and, be able to work full time. And it was just too much to juggle with trying to find time to go to work and then do in-center. And, with my blood pressures dropping, it was just exhausting me. So PD actually worked out better for me, just to come home after work and just do it at night. And then, I kind of got used to the whole routine of doing it 11 hours, and then got called in November. I think I did PD from July to November, and then I got called for transplant. So it's kind of a blessing out of nowhere.
Okay, couple of points about your history.
Mm-hmm.
I understand that when you were 10 or 11, you were diagnosed with type 1 diabetes associated with an autoimmune disease that you picked up in India around 9.
I don't know if it was actually associated or not. They told me the type 1 is autoimmune just because no one in my family has it, and it can have genetic components to it. But since no one in my family has type 1, or there's no history of diabetes in the family, the only thing they can kind of trace it back to is when I got malaria, just because it was so soon after getting malaria in India. Like, I think it was 9 when we went to India, and then I got malaria right after. And then the the type 1 ended up happening when I was 11. So it's the only thing that they can kind of connect, and possibly could have been from the malaria. But again, like, we don't know for sure, but that's one connection that we think might have caused the type 1. So that is what we're thinking might have caused the type 1 diabetes.
Okay. I understand that you've been living with type 1 diabetes for about 20 years. And after medical school, after your residency rotations, you felt weak, dizzy, not well, anemic. Can you tell us a little bit about that?
Yeah. So I came back and I was studying for my board exams to apply for residency. And just kind of out of nowhere, it was like I was walking across the kitchen and would pass out. And then my parents started, like, worrying, like, what's going on with you? And I was like, I think I'm anemic, because I would get, like, out of breath, and, like, studying for my boards, like, I was like, this is definitely anemia, like, the symptoms. And so I called my primary care doctor and told him that, like, is there any way I could get some blood work? I'm not feeling well, and I keep, having these spells. And so he's like, yeah, come on in. Like, he wanted to do a thorough exam, and he called for some blood work. And I found out that at that time that my blood count was 6. So he freaked out. He called a hematologist and sent me over, and we were just trying to find the source of anemia, like, what is going on. Pretty much visited every type of doctor there was, had a colonoscopy, maybe there was a source of bleeding, GI related, or, maybe there was, like, a source of iron, like iron loss that, that I could. So I ended up seeing, since GI, like, there was no source of bleeding, ended up seeing a hematologist at the time in Green Valley, and he thought it was iron. So they were giving me iron infusions, and they noticed that my blood count still wasn't going up. And then my endocrinologist, I had blood work with him, and then it being from my creatinine being from normal from that visit with my primary care to, like, seeing my endocrinologist, like, it had jumped up out of nowhere within, like, 1 to 2 months. And so my nephrologist, my endocrinologist at the time got really worried and was like, yeah, we need to send you for a biopsy immediately. So from that time of seeing my primary care when I was studying to see my endocrinologist for my normal routine type 1 visit, he sent me to see someone to get a biopsy immediately. And the results kind of took some time. They weren't really finding anything on it. So they kept sending it to, a different pathologist just to kind of see if, like, maybe they're missing something. And by the time the results came back, it was probably a couple months after. And usually biopsies take about a week or two to get the results, and they're able to tell you right away, like, oh, it's this. So my nephrologist that had sent me for a biopsy, he said that when he got the results, they're really, like, there wasn't anything that they could treat. Like, they were hoping it was, something like steroids or something could possibly, like, help me regain my function, and, things would go back to normal. But at that time, the only choice was to send me for transplant. So that was unfortunately the only diagnosis I had, as I was at end stage kidney failure. So it was kind of a shock.
I understand that you were sent to the Mayo Clinic in Arizona to be listed preemptively. Is that correct?
That's correct. So he said that there were 2 options. I could go to University of Arizona, or I could go to Mayo Clinic. And Mayo Clinic at the time was transplanting people preemptively, since I wasn't on dialysis yet. And I think University of Arizona at the time, you had to be on dialysis to be listed there. So they wanted me to go ahead he wanted me to go ahead and just go to the Mayo Clinic and get evaluated there before, going to that route, because I wasn't on dialysis yet. And we wanted to start accumulating waiting time before, having to go to that point where I needed to be on dialysis. So my kidney function, I think, was like 2.5 when they found out my creatinine, I'm sorry. And so at Mayo, I wasn't quite ready for dialysis, he felt. So they kind of sent me to Mayo Clinic, and in the hopes that I could possibly start accumulating waiting time and hopefully get a transplant beforehand.
Excellent. So I have the date. The kidney pancreas transplant took place in November of 2009. Can you tell us a little bit about what happened?
Yeah. So it's funny because my second transplant was November 4th, and my first one was actually, I think I got called for my transplant November 4th and ended up staying overnight. And then the actual surgery ended up happening November 5th. So kind of got called for both transplants literally the same day, but different years, of course. And that was 2009 back then. So it was, I got called in the hospital November 4th. I stayed overnight while they did all the testing to make sure that that was a good donor. And then November 5th is the transplant. And I had the kidney and pancreas simultaneous transplant. So,
Okay.
yeah.
How did the kidney pancreas transplant work out? What were the results as far as your kidneys and your diabetes were concerned?
They were great. My surgeon was Dr. Reddy, and he did both and ended up immediately the day after, just, they test your blood sugars, and immediately, like, it seemed like it started working. My kidneys started working on the table. They told me that it started producing urine on the table. And so that was amazing. And then the pancreas started working as well. Like my blood sugars went from high to normal, like immediately. So started producing insulin, and like, it was funny getting my first tray because they were like, well, now you can eat cake and you can eat, whatever you want, and your your pancreas will take care of it. So that was very shocking because I was like, well, I always have to, like, I was able to eat sweets, but I always have to cover it with insulin, and being able to eat and, eat all these sweets and stuff without having to take insulin was kind of a shock. And it took me a while to kind of get used to, like, introducing sugars back into my life that I didn't have to cover insulin for. So definitely took a while. And I still sometimes, even to today, like, kind of have a hard time, like, eating too much sugar, because it's kind of like, 20 years is like, it's hard to, like, go back to normal and not have
Hard
to.
habits to break.
Yeah. And you just get so used to it, and your body gets used to, like, not eating sugars. So, eating low carb all the time. So it's definitely a shock, but I definitely do splurge a lot more than I did back then. So.
Okay. Dr. Patel, some people don't qualify both for a kidney and pancreas transplant and have to live with their diabetes. What's the criteria for doing a kidney pancreas transplant, and how did you fit into that criteria?
So there's a couple of things that the transplant team looks at. There's age. There's also obesity, because, like, if you don't fit in the BMI group that they want, then they're probably not going to end up doing both. Because if you don't fit in that that scale, I think it's less than a certain BMI, they don't qualify, because if you're obese, and it's just not at that BMI to, like, get the transplant, then it's probably not going to serve you well as a transplant patient to get that pancreas, because in the end you might just push yourself over into getting type 2. So they also look at age. So, like, most patients are, like, usually below age 60 to get that pancreas transplant, but they do make exceptions. So, like, if you are over the age of 60, they do look, if you're, like, fit, healthy, like, you're very, very active, then they do consider, like, doing a pancreas transplant for them as well. So there are a couple factors. For me, it was just age, I think, and I was also very thin. So, that played a factor. That, also just having a kidney. I know they told me that having a pancreas with a new kidney, it would benefit me long term, just because the type 1 eventually will destroy the kidney as well. Like, that's just a the pathological like sequence of like having a just the course of the disease with type 1, and eventually ends up eating away, well, not eating away, but like eventually destroying your kidney as well. So they thought it was a better outcome.
It's my understanding that you were doing very well up until about 2 years ago, and then your kidney began to get weaker, so you listed again.
Mm-hmm.
But tell us what happened and where you listed and that sort of thing.
So my doctor, Dr. Nika, she thought that it would be beneficial for me to just get listed just because my kidney function was slowly deteriorating. So she thought it would be better if I got listed preemptively to hopefully accumulate waiting time before I had to go on dialysis. And so we were just kind of pushing time at that point. And she almost thought that, it'd be better if I just got my PD catheter early. And I was just not ready. And so, I was kind of fighting it and pushing time. And then I ended up getting valley fever. And then that kind of just emergently had to start dialysis at that hospitalization. So kind of ended up getting I wanted to actually get PD at that time, but they just didn't feel that, they were hoping that I could just get a PD catheter at that visit, but they said that, because of the infection, it probably wouldn't be in my best interest to get the PD catheter at the time. So we hoped, so they thought, let's start her on hemo, in-center hemo, and then go from there and see how she does and get her at least cleaned up and her blood cleaned up and get her to that point. So then we look at PD.
You mentioned valley fever. I have a date, January of 2021. Is that correct?
Yes, that's correct.
And did you start on in-center hemodialysis or did you start on peritoneal dialysis? I'm a little confused.
Oh yeah. So I wanted to get a PD catheter at that hospitalization. And so that's what like initially we thought. And then when we consulted when my doctor consulted with transplant team consulted infectious disease, they thought, that wouldn't be the best interest just because of the higher infection rate. So they ended up putting in a chest catheter and starting me on hemo. So I started hemo in the hospital, and so it actually helped me in terms of like getting the blood cleaned out, and because my creatinine went from like, being somewhat like I think I was pushing around like 2 or 3 or 4, and then it went to like 12. So they wanted me to get that blood cleaned out immediately. So that hemo helped.
Okay. My friend Kent Bressler is asking, do you think the immunosuppressants had any part in rejection or deterioration of your transplant, your original kidney transplant?
I think they said that it might have, just because it caused scarring. But then also there were other factors, my just, chronic rejection. So it could have been a couple of things. Like I also had a lot of UTIs that, could have caused chronic scarring. Could have been the immunosuppressives. They didn't quite tell me exactly what it could have been because, at the end of the day, like no one exactly knows what causes that long-term rejection. So at the end of the day, like it just was like a slow chronic rejection, but I did probably end up getting 10 to 12 years out of it, and which is kind of normal for having a deceased donor. So we don't know exactly.
Okay. Let's talk about November 4th, 2021. You had a kidney transplant then. Tell us, what happened between the time that you got the call and the time that you came home.
Okay. So I got the call like actually 2 a.m. in the morning. So it was kind of, a shock. I saw the number, and it wasn't actually the number that I always recognize at Mayo Clinic. It was a different number. And so I was like, I don't know if I should answer. And I thought, maybe it might be a spam phone call. Cause usually that's what, a number that I don't recognize is. And I was like, that's kind of weird though at 2 a.m. So I was like, let me just go ahead and answer it. And luckily I was awake. And so I answered it. And it was actually the nurse, one of the nurse coordinators from Mayo Clinic. So she gave me a brief description of what the donor what it would be like. So she said that it was, she couldn't tell me much, but she did tell me it was acute kidney injury. So I would have to start dialysis and to get the kidney to wake up. So I decided to just take the risk and take it. So yeah, I felt
Good
like
doctor.
I felt like it was better than what I was dealing with currently. So, and it has worked out.
Okay. Are there any challenges or complications since your transplant? What is your current condition?
I'm doing great, actually. It took a while to wake up. Ended up having to do about, a couple. I think I did maybe one or two bouts of dialysis in the hospital, and then they sent me home to go to do dialysis in center. And I think I did. I want to say, one or two rounds, and then they kind of were like maybe one more, and then after that, it just kind of it hung around. My creatinine hung around 4, and then they just stopped it, and they said, let's just see how her kidney does on her own. And so, like, every time they would do so much blood work, and then it just started going down and down and down, and then now I'm hanging around 1.2. So my creatinine has gone great. So it went from like 12 to like 1.2 after transplant. Yeah. So it's been great. Yeah.
Well, I'm very pleased for you.
Yeah. We were so
congratulations.
Oh, thank you.
Let's talk about your clinical experience and the studies that you referred me to. Okay. I covered a little bit of that in the introduction, but just so people know, you have over 8 years of clinical experience and research in the areas of psychiatry, pediatric solid and liquid tumors, rare disease, solid organ and bone marrow transplant medicine, diabetes, immunology, infectious diseases, orthopedics, transfusion medicine, transplantation, gastroenterology, rheumatology, cosmetic science, dermatology, and ophthalmology. I'm a grocer's kid from Cedar Lake, Indiana. I'm amazed.
Mm-hmm.
Good job, Doc.
Well, thank you.
You've been with the Mayo Clinic Clinical Studies Unit Multidisciplinary Transplant Research Group as a certified clinical researcher since November of 2018. Can you please tell us some of your duties and responsibilities?
Sure. So when I was hired to actually start research in GI. So I actually started working with the hopes to be in GI, and then they wanted me to end up. I ended up actually started on in the Scottsdale side of things at that unit, or in that thing. And there's 2 different clinics. So there's a Scottsdale clinic, and then there's also a clinic in Phoenix. So Phoenix is where I got my transplant, and Scottsdale is more like, just more like outpatient care. And they do a lot, they do pretty much the same thing, but it's more outpatient care. So I started out in Scottsdale, just, hope they wanted me, they basically hired me to work with the Scottsdale GI team. And unfortunately, the studies that they would hope to, when they hope to have me start with were not quite ready for activation quite a way. So then they said, like, let's go to, like, have you transition to Phoenix. And so I was pretty excited because my whole transplant team is in Phoenix. So luckily I was able to, start on some transplant studies. And I started, with a variety of stuff. I started helping out with hepatology studies. And so, I started with hepatology. I started with some neurology studies. I started with like a whole different background than what I was hoping for. And so I got a taste of everything. And then finally I was able to like somehow work. I got hooked up with a doctor in Rochester, and his name is Dr. Sejal. And so he has a multidisciplinary, not a multidisciplinary, but multi-site study. And he's a transplant surgeon. So he took me on, and then, luckily I got to work with him. And I started out with, his team, and then they actually had a new study called Simple. And so that was my first real transplant study that I got to, get experience with.
You wrote me recently. I know you must be doing well out there in the great AZ, because they tell me that you have a new role, maybe a promotion. What's that all about?
Oh yeah. So I went from just a normal clinical research coordinator, and then I ended up getting certified, and then I got SoCRA certified, and then I went from that to certified clinical research coordinator, and then now I've moved up to a senior research program coordinator. And so unfortunately, I'm going to have to leave the transplant team, and then I'm going to be moving into cardiovascular. So hopefully I can help the cardiovascular team, close the gap between clinical care and then research, and help build that connection with the build to help research and clinical care become better. So I'm really hoping to do what I can for them and help expand the cardiovascular team. Yeah.
Excellent. We got smart doctors on the Jim show. Wow. Let's talk. You wrote me. Let's talk about some of the studies that you wrote me about. Tell us a little bit in plain English about the Freedom 1 study.
So that's basically it's a investigational it's post study, an investigational product called FCR001. And it's a stem cell based product, and it comes from cells collected from the kidney donor's blood, and it's infused into a kidney transplant recipient who has been assigned to receive FCR001. And then the primary objective is to evaluate the proportion of the FCR001 recipients who are free from immunosuppressants. So it's hopefully going to help, patients get off immunosuppressants that have gotten a kidney transplant. So that's what the hope is. And that would help their quality of life. That would help them, as we all know, as kidney transplant patients, we know that being on immunosuppressants, for life, it just, it takes away from, just your quality of life. You have to take a bunch of pills in the morning and at night. And then also just long-term, the immunosuppressants in them in itself help. Don't quite, they do have a lot of side effects. So we're hoping that this Freedom study helps patients get away from those side effects. So we're hoping that,
Is this connected to the tachycholemia study that you wrote me about, the FCR001?
So there's a couple of studies actually. There's Telaris, and that's the Freedom study. And then there's also an antibody mediated rejection study, and that's called HANSA. And that purpose is to help, learn, and that's using an experimental drug, and that's called imlifidase. And that's going to be, hopefully the primary endpoint of that study is to help maximum reduction in mean DSA levels at any time point during, the 5 days follow-up following the start of the treatment.
Okay. So, you wrote me about eliminating donor-specific anti-HLA antibodies in treatment. Can you talk a little bit about that study?
Sure. So that one is actually Imagine. So that one is looking at an investigational product called C1 esterase inhibitor, and that's going to be helpful for treating antibody-mediated rejection. And so that helps compare the standard treatment, which for C1INH is a national protein in your blood, and it helps control the immune system. And C1INH medication called Baranet has been approved for patients who are missing the protein and have inherited disease called hereditary angioedema. So that's supposed to help with that. And that's the imaging study that we have.
Okay. You mentioned earlier in our discussion about a simple study.
Oh yeah.
What's the simple study about?
So that's looking at whether, most people who have gotten a kidney transplant are put on a transplant drug. So we're looking at whether twice a day tacrolimus versus once a day, which is Invarsys, people have with whether are you on the twice a day?
Yes, ma'am.
So
9 in the morning, 9 at night.
So we're trying to see whether, some centers are fully Invarsys, which is once a day, and some centers are just twice a day. So we're trying to see if, one type of drug versus twice, the twice a day drug, if patients are having better quality of life. So if, it'll be kind of a study to just help see if medication adherence, depending on patient-reported outcomes. We're going to look at, just the long-term data analysis and see if there's anything that we can say, like whether patients like one drug over another, and see if like that could help change standard of care for patients on once a day or twice a day. So that's what simple is.
Okay. You wrote me about a pilot study. Can you talk about that a little bit?
I did. So that study is so there's another study that we're looking at, and that's like the role of genetics and socioeconomic factors in outcomes after kidney transplant in Hispanics and American Indians. So we're kind of looking at the purpose of that study is to help, develop tools to help assess socioeconomic risk factors and to help identify genes associated with transplant outcomes in Hispanics and American Indians. So we're kind of looking at, trying to hope for a better understanding of these factors to help guide, management and improve future outcomes in this.
Okay. You mentioned a study to me that's not quite baked yet. Something coming up in the future. Can you talk to us a little bit about that, with the understanding in my audience that they can't apply for the study at this point in time?
Oh yes. So there's actually a couple studies. There's the COVID study that we're looking at, because most of us we can't get the vaccine, and we're not getting antibodies. So this study is hopefully in the future going to help to see if if there's different factors, such as like reducing immunosuppressants, or doing certain things that we can help patients get the reaction that we want, the antibodies that we want to help protect us against COVID. So that's what that study is looking at.
Okay. Of the projects that you've worked on for Mayo in the field of nephrology or kidney transplant, which are you the most proud of?
I would say simple, just because we're almost done with that study, and we're looking at, trying to see if Invarsys or twice a day is better for our patients, because Invarsys has less neurological effects. So we're hoping that we're trying to find out if our patients do better on Invarsys or twice a day.
Okay. What is the motivation for your work? Why is your work so important to you? Why do you work so hard?
I feel that all this research is really we're hoping to find better outcomes for patients. We're hoping to find better treatments. So I really like the fact that we can help improve their lives. So I really enjoy my job and wanting to help improve patients and, helping improve transplant. So that's why I like this job.
Okay. We're in the home stretch here, Doc. Is there anything today that you would like to mention before we conclude that we have not discussed, or anything I forgot to bring up that you think is important?
I think we've covered pretty much everything. Yeah.
Okay. All right. Let's talk a little bit about some of the upcoming broadcasts that I have here and on the Urban Health Outreach Media Network.
Okay.
On January 28th, Lisa Thompson is coming on to the Urban Health Media Outlet Network. She's from the NKR and the NKDO. She's going to talk about her kidney story and her advocacy work. On February 4th, on the Urban Health Media Outreach Network, Dr. Andrew Laza is going to come on. He's going to talk about genetic testing and how it applies to his practice with kidney patients. On February 11th, one of our good friends, Shane Blanchard, is coming back. Remember how he talked about how difficult and almost impossible it was for him to get a transplant? Well, he's been transplanted, so he wants to come back and talk to us about his new kidney. Mm-hmm. On February 18th, my good friend from Ireland, Colin Clifford, is coming on to discuss his 1, 2, 3 kidney transplants and his work. He actually makes tacrolimus at his job, so should be interesting. February 25th, Stacey Ramonde is going to be on with us on the Urban Health Outreach Media Network. She wants to tell you her kidney story. So we're looking forward to all of that. I want to thank you tonight, Dr. Patel, for coming on with us. Boy, I learned so much in the last half hour, 40 minutes or so. I just want you to know I really appreciate it. Thank you so much for coming on.
Thank you.
All right.